Hey guys, thanks for joining. Today we're going to talk about mastering the airway and assisting with intubations. All right, so how do we actually figure out when we need to move forward to intubating, right? We have our primary survey, and in our primary survey, we have our airway assessment and our breathing assessment. And we never want to move past the A and the B, and then what comes next is our C, right? We never want to move past that until they're addressed. We want to make sure that if there's a problem with the airway, we stop there, we fix that. If we fix that, we move to breathing. If there's a problem with the breathing, we stop there, we fix that. We don't necessarily ever want to actually go beyond that and not fix the problems. So we're really going to focus on the A and the B in this presentation. So our airway, we want to make sure that airway is open so they can take in oxygen, they can expel carbon dioxide. And breathing, we want to make sure that they're actually able to breathe so that they can bring in the oxygen and expel the carbon dioxide. Now, remember that in really hectic situations, and this can happen when you have a patient that you think you're potentially going to intubate, things can get really crazy really quickly. So just always fall back on your ABCs. Check that airway, check the breathing, check the circulation. Realize that stress is very real and it's very distracting. So just stick with these basics that we're going to talk about, and I'll help you get you through all of the situations that we're going to encounter. All right, so we have that primary survey, the airway assessment, the breathing assessment, and now we're going to talk about some BLS airway maneuvers. So your first step, you're doing that primary survey. Is your patient responsive? Are they talking with you? If so, you might be able to just coach them through the respirations, have them sit up, have them take slow breaths, have them try to cough. Let's say we're not lucky and we don't have a responsive patient that's able to do that with us. They're unresponsive, but they have a pulse. So we need to make sure that we're going through our primary survey, right? So we do our A and our B. We need to check the patency of the airway, and we need to check the respiratory drive, that breathing. So there's kind of two caveats that we can have. When we first check our airway, if we hear noise from the airway, so the big one I think of is snoring, then I think the airway is compromised. Now it can be the tongue that's in the way. You can hear gurgling if they need to be suctioned. Really sounds in the airway are telling you that the airway is compromised. There's a couple of BLS airway maneuvers that we can do. We can do a jaw thrust, okay, where we actually hook our fingers underneath the corner of the jaw and we lift it forward. That helps to displace the tongue. We could suction. If we don't have a concern for any neck injury, we could do a head tilt chin lift. We're able to open the airway that way, and you can see some nice pictures here as to how we would achieve that. Well, let's say you did your assessment and you're like, okay, well, there's no sounds from the airway, but now what? Well, we've checked our A, we've checked our airway. Are they breathing on their own and with the normal pattern and rate? If they are, great. Maybe we apply some oxygen. Let's make sure that we really continue to reassess. Let's move on to our circulation and the rest of our primary assessment. Well, let's say they're not breathing on their own. Well, we're not going to move on to the other stuff. We're going to stay right here in the B section. We're going to say, okay, we're going to assist the ventilations. So we're going to use a bag valve mask, a BVM, to help them breathe. Now we could consider using something like an NPA or an OPA, and we'll talk about that in a little bit, to help to maintain the patency of the airway. But we want to make sure that we cover our airway and our breathing. So we're going to start assisting with that if they're not doing it on their own. And when we give a breath, we only ever want to squeeze the bag enough to see the chest rise. And that's it. And then it falls. We don't want to squeeze the whole bag. We don't want to double handle it and try to compress the whole thing. These big adult bags contain about 2.5 liters of air if you fully compress it. And our little lungs usually don't need more than 500 mLs. So one-handed squeeze until you see that chest rise, and then you're done. All right, well, let's say you did all the things, right? You checked your airway and you're like, ooh, kind of questionable. I hear some gurgling. I'm going to suction it out. Now I hear some snoring. I'm going to do a jaw thrust. Well, they're not breathing, so I'm going to breathe for them. Maybe I'll put that OPA or NPA in so that I can maintain that airway patency. And now I'm breathing for them. Great, I fixed those problems. Well, what do I do now? There's 4 reasons to intubate somebody, okay? First one, failure to oxygenate. We're seeing no improvement in our SpO2 despite any medications, non-invasive airway maneuvers, techniques, nothing. We're just not seeing them oxygenate. We're going to go ahead and intubate. A failure to ventilate. Air exchange isn't happening. You can see this in apneic overdoses. You can see it in end-stage COPDers. They aren't ventilating. Air isn't moving in, air isn't moving out, and it's not changing. They get intubated. Failure to protect their airway. They're unresponsive. They have blood secretions or vomit in their airway and they can't clear it. They have no gag reflex. They get intubated. And then a failure to improve or expected clinical course. somebody that you know that is going to be going directly to an OR or directly escalating care when they arrive to the next facility, they can safely be intubated. So these are your 4 reasons to intubate somebody. They're not oxygenating, they're not ventilating, they are not protecting their airway, or it's an expected clinical course and you feel that you can do it safely. 4 reasons. Okay, preparing our equipment. Now, our respiratory team is fantastic and they have everything that they need at their fingertips to be able to set up. But let's say that maybe they need a little extra help, right? Maybe we've got multiple crises going on at the same time. So we want to still be familiar with the equipment and the material, even though we know our respiratory staff are the ones that primarily use this and get this set up. So let's just talk about the different aspects here. So we have a BVM. That BVM is the bag valve mask. It has a mask here. Typically a filter is going to get placed because of COVID. We have this bag. Now, sometimes this bag can actually be compressed. So this piece and this piece are kind of like pushed into this middle cylinder. So you just grab each end and pop it open. This end connects to an oxygen device. Unlike a non-rebreather, you don't have to fill this bag. You know how when you set up a non-rebreather and you have to put your fingers over the little holes inside the mask to allow the bag to fill? You don't actually need to worry about this bag filling. Plug it into oxygen, hook it all the way up to the max, which looks like 15, but if you really crank it, it actually goes up to about 25 liters a minute, and that's your BVM. All right, that OPA and NPA that I was talking about that we might have already been using for our BLS airway maneuvers, that's an oropharyngeal or a nasopharyngeal airway. So they're 2 different things. And why would we choose one over the other? It's a couple reasons. Our OPA works really nicely where it slides in, it just displaces the tongue, so then you can see that there would be nice airway movement here. But you don't want to use that on somebody that has a gag reflex still. So some of these patients, they might have a gag, but they're just failing to ventilate or they're failing to oxygenate. So when we talked about the 4 reasons to intubate before, people aren't going to have all 4 reasons. They might just have one of those reasons, and that's completely fine. Because they only have one of those reasons, it can make it a little bit tricky. And so we don't use this on somebody that has a gag reflex. And we measure it from the corner of the mouth to the corner of the ear, and that's how you get an appropriate size. If you don't measure it and you put one in that's too big or too small, it's actually going to cause a worsening problem with your tongue and some of the structure displacement, and it can actually make it harder to ventilate. So make sure that you always measure it. And then an NPA is a nasopharyngeal airway. So makes sense, it would go in the nose, right? This is one where you measure it from the corner of the nose to the tip of the ear. You do need to put quite a bit of lube on it because you can imagine that it's actually going to go into the nair and it follows along back here. And then it kind of ends right above the airway here, and it just allows for a nice patent airflow, again, making sure that the tongue doesn't get in the way because now you have the secondary airflow track to follow. Well, this is one that can be really nice in patients that have the gag, but it's not one that you would want to necessarily use in a patient that has severe facial trauma because you don't actually know what's going on with their bone structure from the trauma. And so you don't want to put anything up the nose that could potentially go into a wrong area, aka up in the noggin. So just keep in mind, why are you placing this and what would be the most appropriate for the patient? And again, always make sure that you measure this one as well. All right, what about our ET tube? So that's our endotracheal tube. It has a couple of different things that you need to be aware of. So most of the time, you're going to see people get what they call an 8.0 tube. They'll say, yeah, grab me an 8.0. All of the tubing packaging is all labeled with the different sizes, and it goes anywhere from a 1, 1.5, 2, all the way up to, I think the biggest is either 9.5 or 10, which you like very rarely ever see. Most kits, the biggest size that they carry is an 8.0, and the 8.0 is talking about the diameter of the inside of the tube. Now, why would we want bigger rather than smaller? You would think, well, maybe smaller would be easier to place. You want it bigger because you're thinking if you've got air flowing through it, you want to make sure that the air flows smoothly and evenly and doesn't get high pressures just because the tube itself is small. So now we're having ventilation issues. So all like little extra tidbits, but you will see it commonly called 8.0, 7.5, 7.0. That's what they're talking about, is the size of the ET tube, which again is on the packaging. You can also typically see the size on our ET tubes, at least, is written up a little bit higher here. It'll say 8.0. On this one, it's written way down here. But if you think about it, if they're intubated, all of this is in their mouth, so it's a little hard to see. So that's where you tend to see it on ours. Now we have a couple of other things. This is the connector, so that connects nicely to your BVM or the ventilator. This is what's called the pilot balloon, and that's where you'll see the respiratory therapist attach a 10 ml syringe of air. So then that way, when the tube is placed through the vocal cords into the trachea, they can inflate this cuff, which helps to keep the tube in place. This is called a Murphy's eye, and the only reason that we really care about that is we actually use a stylet, and that's a hard, malleable metal rod that goes in here that the provider is able to use to help to guide the tube in through the vocal cords. And we never want that to pass past this Murphy's eye, because what happens is this is a fairly soft plastic. If you have that metal stylet come past this eye and go beyond here, it can actually cause damage to the local tissue structures. And so you just always want to make sure that it doesn't go beyond that. Again, respiratory is phenomenal and takes care of this, but it's just kind of nice to know some of these pieces. Okay, there's a couple of different style blades that you can see. So what happens is the provider will have a handle that's separate from the blade, and they decide what type of blade that they would like to use. And there's two different types. There's a Mac, which is curved, and a Miller, which is straight. And they all have different sizes. And again, it's written on the side of these. So how it's positioned here, if you were to turn it and face it towards you, you would actually see the size written out there. So if you're ever asked anything, that's all you have to do is just hand them that. Never forget your suction. So make sure that you've got a full suction setup. And that includes the canister, the tubing, the Yankauer, and the tubing to connect the canister to the suction device. That's one thing that I noticed that gets forgotten a lot, is the actual tubing that connects from the canister itself to the suction device in the wall. Make sure that's all there. You have that 10 ml syringe that you're going to need for inflating that pilot balloon, some type of an end-tidal CO2 device, which we're going to talk about a little bit more. It's extremely important. And then there's a lot of other pieces that we're going to need as well. We have a special securing device. That's the sticker pucks that go on the cheeks and then comes across the top lip that you can tie the ET tube onto and then ties around the back of the neck. That keeps the ET tube safe and secure. You could see a video laryngoscope setup, and that's typically what we've been seeing with COVID. So we call that our glide scope, and that's a piece of equipment that we do have on MedSurg and an ED, and they're able to actually go in and visualize the cords on a camera so everybody else can actually visualize the airway. What's called a bougie, which is a long, thin blue stylet that you can use if you have a patient that has a really anterior and a difficult airway, because it's able to be manipulated a little bit differently than just the traditional tube. We've got supraglottic airways, so those are our LMAs that you can place without having to have without doing a full intubation. And what it does is it goes in and it just kind of sits right above the trachea and the vocal cords, and a balloon inflates to hold that in place. It's not a definitive airway though, because it's not actually going through the vocal cords into the trachea, which is making sure that it's truly going into the lungs. When you do a supraglottic, you have the potential to still have air escaping into the stomach. There's the potential for surgical airway, and we're going to talk about kind of all of our planning purposes for intubation. And so our respiratory staff has this really amazing airway cart. It's blue, it's downstairs in Trauma 1, and it has all of the backup resuscitation airway equipment in it, and that would include a surgical airway kit. And then we have the whatever ventilator that they're choosing to use for that patient, with all of the filters that are required for COVID, as we're quite commonly seeing that. And then we want to make sure on the nursing side, you know, we're helping to support our respiratory folks and our patients and our providers. But we want to make sure that we've got our own meds situated. So we want to know what our induction meds are going to be, our paralytics, and what our post-sedation med plan is going to be. We're going to talk about all of that in a little bit. All right, just a baseline. Again, this is more of the provider, but I really want to empower the staff to recognize when they should be concerned about things. Do we think this intubation is going to be challenging? How do we actually know that? You know, there's a couple of different things that you can look at and will give you clues as to whether or not you think the intubation is going to be challenging. The reason that I want our frontline nursing staff to be able to recognize this is so that you can kind of preemptively think, what might they ask me for if they have issues with this patient? You know, if I'm in the room and they have a full setup and they're getting ready to do a intubation with a MAC 3 blade and an ET tube, and I look at the patient and I say, ooh, I think that they meet one of these lemon criteria that we're going to talk about in a minute, I'm going to make sure that I know where the backup airway equipment is, because we have concerns. You can verbalize it to the provider. Hey, I'm kind of concerned about this. What do you think our backup plan is going to be? So when you're trying to assess airway level difficulty, there is this lemon mnemonic that's pretty common. And so the first one for the L is look externally. So what do you see when you look at the patient? If they have a large body habitus, their head and neck anatomy, so they have a really short neck, they have a really small mouth opening, so they can only open so wide, or they have significant prismus, which is that tightening of the jaw, so they can't actually extend their mouth open very far. If they've got loose teeth, or if they have really prominent teeth, if they have any jaw abnormalities, if they have a big beard, which would kind of make it difficult for you to actually be able to see the underlying facial anatomy and structure. Those are all things that should make you go, Okay. The E is evaluate the 3-3-2. So the 3-3-2 is something that providers will use, and actually I see it used in the OR really well when they're doing their airway assessments, because all of their intubations for the most part are elective, and so they're able to do these really nice airway assessments because their patients are conscious and able to actually follow commands, unlike some of our patients that we encounter when we're having to do a more rapid or emergent intubation. And so the first one is, can they fit their 3 fingers between their incisors? So can they open their mouth wide enough to fit their 3 fingers in? That gives you a little bit of an idea of how much flexibility of their jaw. Is the mandible length 3 fingers from the mentum or the hyoid bone? So from here to here, is that 3? Some people don't have much of a chin, and so it leads you to think that might be more anterior of an airway. And then the 2 is the distance from the hyoid to the thyroid. So from about here down to your thyroid, is that at least? That's kind of what we're looking for to see if it's difficult or not. A Malampati is something that you might hear. And again, that's when you have the patient open up their mouth and stick out their tongue. And you want to see how many of the posterior structures you can actually visualize. And this might be one that you see a provider do if the patient is conscious and able to follow commands before they do an intubation. Obstruction or obesity. So obesity is a big one. It can be really difficult to displace that much tissue in the head and neck to be able to actually visualize an airway. But also if they have anything else going on if they're in their neck. So if they had head or neck cancer, if they have any hematomas, if they potentially have a foreign body, if they were a burn and they have thermal injuries, there's a lot of things. So anything in this region that's abnormal needs to be discussed before the intubation starts. And their neck mobility. Are they somebody that has the ability to move their head around? So then when we're actually going to do the intubation, we have some manipulation of the head to get a better view of the airway, or are they somebody that's very stiff and cathodic and can't actually move? So all of these things are something that the providers are looking at, whether they're verbalizing it out loud to you or not, to see how difficult the airway is going to be. Something that I do want you to be aware of, though, because you could be doing this, is when you use a BVM to actually ventilate the patient. That's a BLS skill, something that we practice in the lab. It's practiced when you do your BLS and your ACLS and your PALS. And so the mnemonic moans is a way to recognize if you think you're going to have a challenge with that. So if they're male, sometimes it can just be a little bit more difficult, their facial structure. And if you have a poor mask seal, if they're obese or there's any type of obstruction, their age, if they're older, if they have no teeth, it can actually be really hard to hold that jaw and facial structure together to be able to bring it up into the mask to give a good breath if they have no teeth. And if they have a stiff neck or if they have snoring respirations, because it's telling you that there's airway compromise. And if you have a patient with any of those things, use a 2-person technique. Don't feel like you need to try to fit your hand over the mask in their face and be managing the bag as well. And you have a big air leak on the side because they don't have any teeth. And so their cheeks flapping when you're trying to bag them. Don't do that. Go ahead and just say, hey, I need somebody else to come over here with me. I'm going to do a 2-handed technique. I'm going to make sure that I have the mask. I pull their face up into the mask, so you get a nice seal. I'm going to have my partner squeeze the bag until I see chest rise. Okay. All right. These are the quick 8 steps, if you will, the 8 Ps of intubation. We're going to break down each one. So our preparation, we decide we're moving forward with intubating this patient. This is what I want us as a team to be working towards. So let's grab a bedside table. Let's make sure we get all of our equipment nearby and easily accessible where everybody knows where it is. I'm going to position the monitor so that I can actually see it. I don't want it behind a whole bunch of IV fluids that are hanging on a pole right in front of it so I can't see my numbers. I want to make sure that I can see it visually from wherever I am in the room. And I'm going to change my blood pressure cuff to cycle every 2-3 minutes. So then that way I can get accurate blood pressures throughout on induction, because we're going to be giving medications that are definitely going to change that. I want to make sure my SpO2 probe is working. If it's in a bad spot, if it's not working, I want to change it. So get a disposable, get a non-disposable, get an ear clip, get something so that you can get an accurate reading on your SpO2. That's very important with a good plus. We're going to want to put on our end-tidal CO2. That's going to be more of our respiratory folks, but we want to make sure that that's readily available and can connect to our monitor, because that's the gold standard for assessing if our ET tube's in the right place and for managing their ventilations once we do the intubation. Want to make sure that we have 2 oxygen sources, because we're going to have our non-rebreather in one, because we're going to talk about preoxygenation in a minute. And then we want to make sure we've got something for our BVM. And then we know that we already have our vent that's going to connect to the wall. So we just want to make sure we have lots of oxygen sources. That suction needs to be on, it needs to be on high, and easily grabbable by the provider. It shouldn't be something that you're trying to set up, and I want you to turn it on and actually like assess it. Is it suctioning? Is it have good suction power? Leave it on, tuck it under the head of the bed. Make sure the provider knows where it is. Check out your IVs, make sure your IVs are working and they're working well. And if respiratory isn't present, make sure that somebody pages them so that they can actually get up and start setting up their equipment and getting their ventilator ready. And see if you can have a runner outside of the room to be able to get any miscellaneous piece of equipment. As well prepared as you are, there's usually always something that needs to be grabbed from outside of the room. So just see if there's somebody else that can help with that, and then start having a conversation with your provider about what medications you're going to be using. And so a SOAP me mnemonic can kind of help you to remember these things. So if you go through SOAP me, we've got S is suction, O is our oxygen, A is our airway equipment, P is our pharmacology, so what meds are we giving? M is our monitors, and E is our end-tidal. And that's a very quick down and dirty. If you think SOAP me every time you do an intubation, you're going to make sure that you've got the majority of the equipment that you need to be safe. Our second P is positioning. So we want to make sure that we have a couple different axes, right? We've got an oral axis, pharyngeal axis, and a laryngeal axis. And our goal when we do an intubation is to try to align these axes as much as possible to make it easy for the provider to see the airway so that they can actually place the ET tube correctly. So it makes for a more successful first pass attempt. So in somebody that's obese, this ramped position can actually be really nice, because it helps to bring these structures a little bit more together. Sometimes you'll hear what's called a sniffing position, where you kind of pull that chin up a little bit higher. And that can actually be beneficial if you tuck a towel up underneath the shoulders. Sometimes you'll have patients where they just say, they want their head elevated a little bit. What I've seen recently here is we'll actually keep the head of the bed about 30-40 degrees, and the provider intubates more at an angle, and that's helping to keep the patient in line. And then just keep in mind that if you have a suspected neck trauma, you really have to be mindful of the spinal manipulation. But airway is paramount. If we don't get an airway, then it doesn't actually matter what happened to the spine, because the patient won't survive without an airway. So just keep it in mind if you're working with a provider. And then make sure you position them well in the bed. Pull them up, get them nice and high. Make sure that you raise the level of the bed so that it's at a comfortable position for the provider to intubate, so that they're not crouched over or they're not really high where they can't actually get a good view. Make it work for everybody in the team. Our third P is preoxygenation. My recommendation is that we put all patients on a nasal cannula and a non-rebreather together and set them both at 25 liters. Why? So what this does is when you do that, it ensures total nitrogen washout of the lungs and establishes extra oxygen reservoir in the lungs. So nitrogen is actually a fairly big molecule compared to oxygen. I'm not very good at making big and small molecules, but when you wash out the nitrogen, you leave a lot more space for excess oxygen. And we have an additional benefit if we do this, because when we take the non-rebreather off to actually do the intubation, you can't do it through the mask, right? You take it off to do the intubation, leave the nasal cannula on. And what you're actually going to get, you're going to get passive apneic oxygenation that's occurring. So that oxygen is still going to continue to flow through the intubation process, but it's going to passively oxygenate the patient, which can prolong the time before they desaturate, in which you would have to stop the procedure in order to bag them back up, is the phrase that you tend to hear, where we use a BVM to bag them to get their oxygen sets back up. Now, I want you to look at this graph here. And what this is telling you is it's showing how different patient populations can desaturate during an intubation attempt. And so the fastest that you'll see that drop are our obese patients, okay? And then we've got these, our kids who start out high and they drop off pretty quickly. Then we have our moderately ill adults, which can maintain for, looks like a couple of minutes before they drop off quickly. And then we have our healthy adults that can maintain for quite a while before they drop off. And so when we pre-oxygenate, we do the apneic oxygenation during the intubation by leaving the nasal cannula in place. You give the patient the best chance at maintaining an appropriate SpO2 for the longest amount of time. All right. If for some reason you're actively bagging the patient with a BVM, still put that nasal cannula on because it'll still allow for that passive oxygenation once the BVM comes away and the intubation attempt begins. Okay, our fourth P. Here's our pause. All right. We want to review all of our equipment, review our plan, our meds, and talk about any questions or concerns. Because once the intubation starts, we want to minimize distractions. So this is a checklist that I used when I worked at DART. We've made a new checklist for Valley, and we have it printed and laminated. It's on the glide scope, it's on the Airway cart, and it really just talks about let's pause, let's check our equipment, let's make sure we have everything. Do we have any questions or concerns? Take a deep breath and then move forward. Every emergent situation needs this pause moment somewhere. So this is when we need to take it. All right, our fifth P, our paralysis with induction. So a rapid sequence intubation, right, is a simultaneous administration of this sedative, so your induction agent, and a paralytic, which allows them to become immediately sedated and then flaccid to have an emergent intubation occur with a minimized risk of aspiration. And that's the goal. It's a first pass attempt success. And that's what we really want. So one thing that I want to go through are the medications here. So we've got a couple of different induction options. We've got etomidate, we've got ketamine, we've got midazolam, and we've got propofol. And so we're going to talk about these a little bit. So etomidate is a sedative hypnotic, okay? The dose is 0.3 milligrams per kilogram. IV push. And what happens is the time to effect with this, it takes about 15 to 30 seconds once you give the medication for you to start to see sedation. It lasts about 3 to 12 minutes and it has no pain effects actually. And so this is one where once you give the medication, you want to always be thinking in the back of your mind, what am I going to give next, right? What am I going to do? Okay, ketamine is a dissociative anesthetic. The dose is about 1 to 2 milligrams per kilogram, and that's that slow IV push. We talked about this in another lecture, but if you give it fast, you give it rapidly, it can cause pretty significant laryngospasms. It takes about 45 to 60 seconds in order to actually take an effect, but it lasts about 10 to 20 minutes. So this one gives you a little bit of extra time versus that etomidate that only lasts about 3 to 12 minutes. And ketamine actually does have pain properties, which is excellent. Midazolam. So Versed is something that, So Versed is a benzodiazepine that can be used with a common dose of 0.1 to 0.3 mg per kg as an IV push. And it only takes about 30 to 60 seconds to get into the system and lasts about 15 to 30 minutes, depending on the patient. And it, again, doesn't have any pain properties. And then our propofol is that lipid-soluble medication that causes sedation and amnesia. Typical dose is 1.5 to 3 milligrams per kilogram as an IV push. Takes about 15 to 45 seconds before it starts to kick in and the patient starts to become sedated. And it lasts about 5 to 10 minutes and it has no pain properties. So you can see here that with all 4 of the induction medications, only 1 actually has pain properties, and most of them don't last much past 10 to 20 minutes. So keep that in mind as we talk about our paralytics. We have 2 paralytics. We have rocuronium and we have succinylcholine. Rocuronium is a non-depolarizing neuromuscular blockade. So what it means is it actually just stops the impulse before it actually reaches the muscle. And so you see a paralysis effect. Typical dose is 1 milligram per kilogram IV push, and it can last anywhere from 20 to 45 minutes. Anecdotally, we've seen in COVID patients, it's actually lasting closer to an hour and a half. Think about that for a minute, okay? You gave say etomidate, which is a fairly routine medication that we see given on these patients, and rocuronium. Well, your rocuronium may be lasting for close to an hour, but your etomidate only lasted about 10 minutes. So this is why it's so important to make sure that you have a game plan for your post-sedation medications to keep them sedated and comfortable and not in pain, because they're going to be paralyzed for close to an hour. So you're not going to see actual movement or crying or biting of the tube or other indicators that they're awake and in pain and not sedated. You're going to see things like their heart rate going up and their blood pressure going up and other indications that they're in pain. But you want to just think of that ahead of time and say, hey, I know that in 10 minutes, that medication I gave them is going to start to wear off and they're still going to be paralyzed. So I want to make sure I have something going to keep them comfortable. And then succinylcholine, that's a depolarizing neuromuscular blockade. So what that means is that rather than the non-depolarizing, where it stops before the motor plate, succinylcholine actually, it causes fasciculations. So it stops the muscles from being able to contract by like pausing them. And so you'll see actually people almost like tremble and shake. And that's the fasciculations that you see with succinylcholine. The dose is 2 milligrams per kilogram as an IV push, and it lasts about 3 to 5 minutes. So it doesn't last as long. There are a lot of contraindications: hyperkalemia, excessive burns, prolonged ICU stay. And so you really just want to be cautious in using it because for some patients, it's not the best. You also tend to never give more than 2 doses. So let's say you give a dose of succinylcholine and you have a failed intubation attempt. You bag the patient up. Now they're not paralyzed because it only lasts 3 to 5 minutes. You give another dose of succinylcholine and same thing happens. Well, it works off of, and I'm not excellent with this piece, so if it's something that interests you, definitely look it up further, but it works off the muscarinic receptors. And so if you give too much succinylcholine, it can actually give you a similar response like you would see in an organophosphate overdose. And so it's not something that we ever use more than 2 times in a row. And that's why a lot of times you'll see if a provider uses sux for the first dose and they're not able to get the intubation for whatever reason, and they want to do a second attempt, that they usually will ask for rocuronium instead. Okay, so we pushed our meds, and our provider did a great job in visualizing the airway and passing the tube through the cords, and now it's in. So you're like, fantastic. Well, now what? So immediately after the tube gets placed, the provider is going to remove that stylet or the bougie. So that was that firmer inner stylet that went into the ET tube to make it easier to position. That gets removed. The pilot balloon gets inflated, and then the BVM goes on the end of the ET tube. Now, we need to make sure we do a couple of things, okay? When that ET tube first goes in, before it's secured, you have to make sure somebody's actually holding it. And the providers are excellent where they actually just hold the tube right at the base, right at the teeth. They'll tell you where the tube is. So they'll say we're 25 at the teeth, and you can actually see number markings. So you can measure the depth. So they'll tell you where they're at, they'll hold it, and then you'll actually bag the patient. And the respiratory therapist is going to secure the tube through that securement device that we talked about earlier. But we have a couple of things that we need to make sure that we assess to make sure our ET tube's in the right place. We want to check our end tidal CO2, okay? If we use a colorimetric device, it's a square box, and when you put it on, it goes from purple to gold, and the gold is good. Gold means that they're getting exhaled CO2. As soon as we have that, we want to make sure that we connect them to the continuous end tidal CO2 monitoring. And it kind of depends on your respiratory therapist. Some of them like to use the colorimetric device initially. Some just go right to the continuous end tidal CO2 monitoring. And that is the gold standard that we connect them to that. And what we're expecting to see is a waveform. And when we see that waveform, we're expecting to see a positive number with that, because that's indicating that the patient is exhaling. So every time we breathe for them and then we release the bag and they exhale, we should see a waveform and a number associated with that. No waveform equals no lungs. So that means that you have an esophageal intubation. Now, you can have the provider go ahead and look back down with the glide scope or with the laryngoscope and say, no, I see that it's through the cords. Maybe there's an issue with something else, but never assume it's the equipment. Always make sure that they double check and make sure that you can actually see it go through the cords, because on really anterior airways, it can be very easy to think that you're about to go into the cords because you can just see the bottom of it, but actually slide up below and end up in esophageal intubation. So make sure that you have that end tidal. And then you want to see chest rise, and you want to see misting in the ET tube, right? And then you want to listen. So listen over the epigastrum, listen right at the base of the xiphoid over the stomach. And you want to say, do I hear anything? When I bag, do I hear big gurgles? Because if I bag and hear big gurgles, then that air is just going into the stomach, not in the lungs. But if I don't hear any gurgles there, now I'm going to go to both lung fields and listen. And when I listen on the right and I listen on the left, I want to make sure that I actually have lung sounds on both sides. Now, sometimes during an intubation, it can be a little challenging to place the tube at the correct depth right off the bat. You get it through the cords, you can see the balloon past the cords, but then there's a potential that it could go a little too deep. And if you think about it, when you have your lung, you've got your trachea, and then you've got the two main bronchi that kind of split. Well, your right bronchi is a little bit straighter than your left. And so if your intubation attempt went too deep, then what you see most of the time is you have breath sounds on the right and you don't have breath sounds on the left, because it's more likely that the ET tube ran along that right side because it's more of a straightened path than the left, which is a little bit more curved off to the side. So if that were to happen, what do? You say, hey doc, I have breath sounds on the right side, I have no breath sounds on the left side. Well, maybe they can go back in with their blade and look and deflate the balloon, pull it back a centimeter or two, and then have you listen again, reevaluate. And you say, yeah, great, now I have breath sounds on both sides. Beautiful. It was just a little too deep in the first attempt, and that's okay. All right, our 7th P is our plan for our failed intubation. So this is if we have to actually use that plan. So sometimes intubations don't go as planned, right? You have this is how it's going to be, and that's what we strive for, but then things happen. And so if there's a missed intubation, there's lots of options. The failed airway algorithm that's right here is just kind of a nice way for providers to be able to work through their different attempts. So just be aware that if for some reason there is a missed attempt, that the provider may ask you to change the blade size. They may ask for a bougie. They may ask for the glide scope if they weren't using the glide scope. They may ask for an LMA or a supraglottic airway. They may ask for the surgical airway coming from the airway kit. So you just have to keep in mind that if an airway fails, we always go to the next step. We don't stop, we don't give up, we don't say, well, this patient can't be intubated. You always move to the next step. And if there's a patient that there's a lot of concerns about the intubation itself, then that needs to be a really good discussion before anything moves forward, so that everybody's on the same page and knows what the plan is if there is a failed attempt. All right, and as long as you can successfully use the BVM to oxygenate and ventilate the patient, you get a good SpO2, you get good chest rise, then you have time. The patient is safe. You have time to figure out a plan. You're not in a can't ventilate, can't oxygenate situation. And that is an emergent situation that would potentially require going to this surgical airway. But if you can bag them and maintain a good SpO2 and get good chest rise, then just take a breath and have everybody just say, okay, this is where we're at. Patient is safe because we're managing their airway and their breathing. What's the next step going to be? Then our 8th P is our post-intubation management. So your ET tube's in, it got confirmed, it's secured, you're attached to the vent now. What happens next? So monitoring. So that end tidal CO2 monitoring, we want to make sure it's attached and functioning. So you can see here, this is the type of waveform that you're going to see. This is when they're exhaling. This is where you're going to see your number. Now, most of the time, a somewhat normal is 35 to 45, but in your really sick patients, their initial end tidal may be 20, 25. And it may be that low because they're trying to compensate for their severe acidosis or whatever it is that's going on with them. So just keep in mind that these numbers aren't always the exact perfect. 35 to 45 is in a very healthy, normal adult, okay? We want to make sure we watch our SpO2 closely, especially as they're getting on the ventilator. And with our COVID patients, we see a lot of times that they do become hypoxic during intubation attempts because they're on such high demand, whether it's BiPAP or high flow. And then you will see a dip, and then sometimes it can take a while for them to actually recover and come back up into a normal range. And then we want to make sure we're checking that blood pressure. How did it do after all those induction medications? You know, we gave a bolus of a medication that can cause hypotension, and now we're getting ready to start our sedation. So where are we looking on our hemodynamics? And then talking about sedation, keeping in mind that most of those induction agents don't last more than 15 minutes, okay, and don't have pain properties. So your patient's going to be awake and feeling pain pretty soon after the intubation. So let's just make sure that we always have something ready. Propofol is fantastic. Fentanyl is fantastic. We can do ketamine infusions. We can do several different things. And that's actually the critical care infusion lecture that you can watch if you haven't watched that one. But make sure you have something for sedation and for pain. Please don't put somebody just on propofol because it's just not enough to keep them comfortable. And then don't forget to get that post-intubation chest x-ray. And if you have the availability to throw down an OG tube, so an oral gastric tube into the stomach before that chest x-ray, then that's great, because then they can get an image and make sure that that's in the correct place, and you can go ahead and decompress the stomach from any excess air that they might have obtained when they were being bagged, or if they had a full stomach, say they came in to the ED as a trauma and they had a full stomach of food, you can actually decompress them of gastric contents that way as well. And it's kind of nice if you can get that OG tube in before the chest x-ray is done, just so you can make sure that it's in the correct place. But that's it for this lecture. So those are the 8 P's of intubation. And if you have any questions, please reach out to me. And otherwise, hopefully for the next intubation that we do here, I'll be around if you want to give me a call, and I can come and work with you, and we can get everybody a little bit more comfortable through this process.